monthly. Next month is Sorgen doing genetic and pharmaceutical
Beautiful.
advances in hearing loss
Oh, wonderful.
repair. So he's one of our local researchers, well known on the stage. So
That's great. Yeah.
so kind of a wide range of just about every, different topics, because I do think that the population needs to be more aware of hearing loss. I think that's one of the things we've certainly lacked a lot, is that that knowledge in the general community about what hearing loss is, from a very basic thing. So genetics, we've covered all kinds of things.
Oh, wonderful. I've got a very well-educated audience then.
So, and I'm sure there are, and people are coming. But it has been absolutely torrential rain and cold in New Zealand. Of course, it's our winter.
Ooh. Yes, yeah, right, exactly. Yeah, my daughter-in-law is visiting. She's from Argentina, and they got married, I don't know, maybe 3-4 years ago in Argentina. And so she's works down there. She's a physiotherapist, actually specializes in vestibular disorders of all things. But applied for the green card and was about to take her last interview at the US Embassy when COVID hit. So they had been separated for several years and finally was able to get here a few months ago. So
nice. I lived in Argentina for about 6 months in Sunchales.
yeah, she lived in Salta, which is a north part of the country.
Yeah. So we have. There we go. Yeah. I want to welcome everybody to this month's Lunch and Learn by Hearing New Zealand. Our speaker this month is Dr. Harvey Abrams. Harvey is well recognized in the field as one of the leading experts. And I've probably known Harvey, 30 years since the Walter Reed, which is a long time when you start to add things up. And Harvey has got to be one of my favorite speakers in all things audiology. And when I was talking to Harvey about what today's topic was, it was more what doesn't he know than what does he want to talk about. And his favorite topic has always been rehabilitation. It's really been very strong in the rehabilitation field because it's not all about instruments, it's all about the person. Isn't that right? And I'm going to leave that to take it away, Harvey.
Well, thank you so much, Lisa. I'm going to go ahead and share my screen here. And we're going to get started. Good. All right, well, thank you so much, Lisa, for your kind invitation to speak as part of Hearing New Zealand's Lunch and Learn series. The more I learn about this wonderful organization, the more impressed I am with your mission and accomplishments. So my presentation today, actually, I'm not going to be talking that much about rehabilitation. Maybe we'll come back and give a nice talk on rehabilitation topics. But in this presentation, I'm going to be discussing some of the research that supports or doesn't support an association between hearing loss and severe chronic conditions. I think this is kind of a hot topic these days. In the interest of full disclosure, here are my financial interests, and nothing I'm going to present today will involve Lively Hearing or any of its products. The agenda today will cover these topics. I want to talk about definition of terms. I'm going to review the literature associated with specific comorbid conditions, and then the effects of amplification associated with these conditions. A little bit on auditory neuroplasticity, some ongoing research that will help to further our understanding of causation, And if we can get to it, implications for audiologists. There's no time. I'll skip that. And then we'll go to questions and answers. So that's okay with everybody. Let's go ahead and start with some concepts. And the first, of course, I think you're all aware of the recent and frequent reports in the lay press linking hearing loss with a number of conditions, including falls, dementia, depression, for example. So this linkage is often referred to as comorbidity. Comorbidity is defined as this: it's the presence of two chronic diseases or conditions in a patient. And this little illustration at the bottom shows you how often the term comorbidity has been used for about the last 100 years or so. And it wasn't until about 1980 that we begin to see it in research papers and in the lay press, and all of a sudden it kind of shoots up. So as I mentioned, very hot topic. So what's a chronic condition then? Is a health condition or disease that is persistent or otherwise long-lasting. And when we talk about long-lasting, in most cases, that term is applied when the course of the disease lasts more than about 3 months. Is hearing loss a chronic condition? I'm glad you asked. Well, under the definition I gave, I would argue that hearing loss would clearly qualify as a chronic condition. And I would argue that it shares many of the same characteristics as diabetes, for example, which I think most of us would agree is a chronic condition. For example, both are invisible, they're progressive, they're painless, they're often incurable. However, they are treatable. Professional expertise is usually front-loaded, and what I mean by that is much of the professional intervention occurs during the first few encounters, after which much of the long-term management is kind of transferred to the patient with shared responsibility between the patient and the provider in order to optimize the best outcomes. Well, here's some other definitions. So as I review the literature, I'll be referring to some terminology that is common in large population or epidemiological studies. It's these types of studies that have provided much of the current evidence that support an association between hearing loss and other specific conditions. And understanding this technology and this terminology, I think, should make you more critical reviewers of some of the information that comes to us through the popular press, for instance. I'm going to talk about odds ratio, and what that means is that it explains or describes the odds that a particular outcome, such as falling, will occur given a particular exposure, such as hearing loss, compared to the odds of that outcome occurring in the absence of that exposure. So, for example, after the study, the researchers might conclude that the odds of falling was twice as likely among people with hearing loss than people without hearing loss. So the odds ratio would equal 2. Now, this doesn't mean that people without hearing loss will not fall, only that their likelihood is less than those who do have hearing loss. Here's another term. And it's called risk ratio, which is the cumulative risk of an outcome occurring over a time span. So researchers may want to study a population over a period of time, let's say 10 years. And at the end of that 10 years, as an example, those without hearing aids had twice the risk of being diagnosed with dementia, that is a risk ratio of 2, than those with hearing aids. And finally, a hazard ratio, which is similar to risk ratio, except it's the risk at a particular time. So for instance, while the study may go on for 10 years, the researchers might want to track the incidence of an occurrence of an outcome along the way. So for example, the risk of having cardiovascular disease among individuals with hearing loss was 1.8 times greater when those without hearing loss than those without hearing loss 5 years following the baseline measure. And the baseline in almost all of these cases means it did not exist. So at baseline, there was no cardiovascular disease, for instance. So with that kind of in our mind and understanding that, let's go ahead and move forward here. And if we look at hearing loss in the context of other chronic diseases, hearing loss is ranked sixth here among people of all ages and genders. But for those 65 to 74, it's ranked third behind arthritis and hypertension. And for those 75 and older, it's ranked second. It's the second most prevalent chronic condition among those 75 years and above, only behind arthritis. Now, it's also important to note that the number of chronic conditions tends to increase as one ages. So it's not unusual for someone in their 70s to have 3 or more chronic conditions. So given the likelihood that for a clinician, the patient sitting across from us will likely have one or likely more comorbid conditions, it's important for us to be knowledgeable concerning the nature of those disorders that tend to coexist or may even be negatively impacted by hearing loss. Here's a partial list of those chronic conditions that research has suggested may be associated with hearing loss. So you've heard the word association. I've used it several times. Healthcare researchers will often use the word correlation to describe a statistical connection between two conditions. So it's important to understand that correlation, a connection or an association, does not mean causation. To be able to say that hearing loss causes falls or depression or dementia requires a different type of research than the population studies that I will be reviewing. As a matter of interest, here is a list of additional conditions that have been linked to hearing loss, and I won't be reviewing these with one interesting exception, and that is mortality. Now, we know that age-related hearing loss makes it increasingly difficult for individuals to hear and understand various sounds in conversational speech, but that difficulty hearing often has consequences in the psychosocial domain. And if left untreated, it can lead to withdrawal, social withdrawal, reduced quality of life, depression, isolation, cognitive decline, and even dementia. I've proposed a model here that illustrates the possible sequela of negative outcomes that progress from hearing loss, which negatively impacts speech perception, which leads to increased communication effort and reduced social engagement, with consequences for cognition, physical functioning, and health-related quality of life. All right, so let's go ahead and review some of the literature regarding these associations. First, let's start with social isolation and loneliness. What does the evidence say about the link between hearing loss and social isolation and loneliness? While these are often treated as separate constructs, I'm going to be combining the two here. Here are some results from a study in the Netherlands, of the longitudinal study on hearing, involving over 500 individuals between the ages of 18 to 70, that supports the relationship between hearing ability in noise and loneliness. The decline in hearing ability in noise was positively associated with increases in loneliness. Systematic reviews involve analyzing many published studies that report on the same outcome. Often, these systematic reviews will reveal results and findings that are not apparent in individual smaller studies, or conversely, they may fail to support significant findings from individual studies when they're combined with the data from many studies. So in this particular systematic review of 14 studies that met the researchers' criteria for review, the results indicated that hearing loss was associated with a higher risk for loneliness and social isolation. So systematic reviews and what they call meta-analyses are very powerful tools to really reveal trends by combining the results of many different studies. Next, I'll review the literature associated with hearing loss and depression. Here's data from what are called Nhanes Surveys. Nhanes stands for National Health and Nutritional Examination Survey. These are common sources of data for health care and health researchers, because they look at tens of thousands, hundreds of thousands of people, and provide large databases upon which researchers can examine links and trends. In this case, depression was measured by an instrument called a PHQ-9, Patient Health Questionnaire 9, which is a self-assessment measure. And the results indicated the odds of self-reporting a major depressive disorder was 1.5. That is a 50% greater odds per every 25 dB of hearing loss in the better ear. The odds of self-reporting any depressive symptom increases to 1.63, or 63%, per 25 dB. The results clearly suggest that hearing loss was independently associated with depression. Now, when I say independently associated, it means that the researchers have taken into account other possible explanations for this association, such as age and obesity and gender and cardiovascular risk. So the researchers statistically remove those contributing factors, so they're able to look at just one factor of interest. And in this case, it's hearing. And the finding here was hearing loss was independently associated with depression. Similar findings were reported in this 12-year review of the Taiwan National Insurance Research Database, which included over 5,000 patients with sensorineural hearing loss and 20,000 patients without. This analysis revealed that the risk of depression was higher in the hearing loss cohort, with the hazard ratio being 1.73, again, a 73% greater risk, again suggesting that hearing loss is an independent risk factor associated with depression. Here's an illustration of what we call a time to event analysis, with time to diagnose depression represented on the lower horizontal axis and the incidence of depression on the vertical axis. So let's take 8 years. Remember, we talked about hazard ratio at a particular point in time. 8 years as an example, we can see the incidence of depression for those without hearing loss is approximately 3.5% compared to those with hearing loss, where the cumulative incidence of depression is over 6%. So almost 2 times the risk of having a diagnosis of depression if you have a hearing loss versus if you don't have a hearing loss. Here's a recent systematic review. Remember, I talked about systematic reviews and a meta-analysis of 35 combined studies involving over 147,000 participants that investigated the association between hearing loss and depression in older adults. The results again support an increased odds of depression associated with hearing loss. Falls is the next comorbid condition on our list. And Lisa, if anybody's has typed in a question in the chat, just let me know, okay? So as we all probably know, falls in the elderly population often lead to serious economic and health consequences, with often fatal outcomes within the first 12 months following a fall with injury in the elderly. The researchers Lin and Ferrucci examined the association between falls and hearing loss in some of these Nhanes surveys and found a significant association between the two, with a 1.4-fold increased odds of reporting a fall in the previous 12 months for every 10 dB of hearing loss. So as hearing loss gets worse, the odds of falling in the last 12 months increase. And this magnitude is clinically significant. So thinking of a 25 dB hearing loss, which is the equivalent of going from normal to mild hearing loss, this is associated with nearly a 3-fold increased odds of reporting a fall over the preceding year. Here is a more recently published systematic review, which concluded that a review of the evidence here supports a relationship between hearing loss and postural control, particularly in the elderly. They concluded that while such an association does exist, the mechanism that explains this relationship is still not entirely understood. So again, the researchers find this association, but the fact that you find it doesn't necessarily mean you can explain the results. However, when other researchers study the relationship between hearing loss and falls and adjusted for the presence of existing balance disorders and dizziness, there was no longer an association between hearing loss and falls. In other words, it was their vestibular or dizziness symptoms that were more likely responsible for the falls, not their hearing loss. So there's not a full agreement on this particular association. Now I'm going to review some of the research linking hearing loss and diabetes. Here are the results of a population study that evaluated the association between the two among over 5,000 participants in an Nhanes survey. Hearing impairment was found to be more prevalent among those participants with diabetes. This systematic review analyzed the data from 13 separate studies involving some 20,000 participants. And the analysis revealed that the prevalence of hearing loss among those with diabetes was more than twice that of those without diabetes. The association between hearing loss and diabetes was independent of gender or chronic exposure to noise. So it's an independent association. In this prospective study, where they followed people for about 12 years, they followed over 253,000 people that had baseline normal hearing. So here is that time to event graph. And let's use 5 years out from baseline. Remember, baseline hearing was normal. And now they're looking at the incidence of diabetes as a function of time and as a function of hearing loss. So looking at 5 years out in time, we see this orange line at the bottom represents people with normal hearing. So again, a certain percentage of them did develop diabetes. Very small percentage, about 1%, but still, even with normal hearing, you can get diabetes. However, contrast this then to those in this group that started out with normal hearing and developed diabetes at 5 years in time, right? So over 5 years, the incidence of hearing loss among those with diabetes was almost 6 times as much as those with normal hearing. Now, what could explain this? Well, it's believed that when people have these high blood glucose levels over time, they damage these very tiny blood vessels in the part of the inner ear called the stria vascularis, a very rich blood supply there. And this blood supply serves to create a healthy biochemistry in the inner ear that essentially provides for normal transmission of neural impulses that send these impulses, sound impulses, onto the brain. And so when those blood cells and blood vessels are damaged, the biochemistry becomes disrupted, and you have a disruption in the transmission of nerve information, neural information from the inner ear to the brain. Now, the relationship between hearing loss and dementia has perhaps received the most attention, at least among those in the hearing healthcare community. So let's explore this research. And the landmark study that elevated the professionals and public's interest in this relationship was conducted by Frank Lin and colleagues, published in 2011. The researchers prospectively studied some 639 participants who were involved in a longitudinal study of aging. And they were dementia-free when they were first recruited into the study between the years of 1990 and 1994, and they were followed for about 12 years. And during this 12-year period, some 58 cases of incident all-cause dementia were diagnosed. Of those 58, 37 were diagnosed as Alzheimer's disease. So the risk of incident all-cause dementia as well as Alzheimer's disease increased with the severity of baseline hearing loss. This large longitudinal epidemiological study used samples from over 150,000 persons from a claims data in Germany. And they were followed between the years of 2006 and 2010, during which time over 14,000 incident dementia diagnoses were made. Gender, age, and other comorbidities were controlled for but patients with bilateral hearing impairment had higher risks of dementia than patients without hearing impairment. And this is probably, I think, my favorite illustration and data set in my talk. And this is a really compelling illustration of the results. Now, again, this is a time to event graph. And you're looking at here at January 1st, 2006, essentially 100% of everybody in this study is dementia-free. Now let's look out in time, 4 years out, and January 1st, New Year's Day, 2010. And what we're seeing here is the percentage of individuals with no hearing loss and no depression depicted by this blue line. And now over time, as people get older and older, increased number of people do develop dementia. So again, even if you don't have hearing loss, you can still develop dementia. Now compare this to this green line, and this represents the part of that population that had hearing loss but no depression. And clearly a greater number of people in that group develop dementia than those without hearing loss. But what is most striking to me is this data. And these are individuals started out with no dementia, but in January 1st of 2010, had hearing loss and depression. So the combination of the two really created a tremendously increased risk for dementia over time. So what might explain this hearing loss cognition association? Well, in a recent article by Harris and colleagues, the authors posit a set of theories to explain this association. And four theories. One is a common cause, that is hearing loss and cognitive decline, occur in parallel as a result of some common underlying pathology. So it's not that one causes the other, but there's some underlying pathology that causes problems in both. And next is what's called cognitive load or perception. That is cognitive decline in and of itself. So people are, their cognition is declining. This reduces the amount of cognitive resources that they have that they can allocate to paying attention to auditory signals, particularly in adverse listening situation. That's 2. 3 is kind of the reverse of that. It's information degradation, is that hearing loss increases demands on cognitive resources, and it shunts resources away from other cognitive tasks, such as attention and working memory and speed of processing, for instance. And the 4th is sensory deprivation, that hearing loss causes kind of a reorganization in the brain. And we'll talk about this a little bit, this idea called neuroplasticity. Now, if you look at this in this illustration, you can see how each of these theories are kind of connected to one another. They're not there in isolation. So let's go back to that model that I presented early in the talk. You may remember this. And let's update it given the information that I covered in the literature review. So I added loneliness and depression to the model and dementia as a potential final consequence. Right, so if you're not depressed enough with this information, it turns out hearing loss can even kill you. And here is what's called the Reykjavik Study. And this involves some 5,000 Icelandic individuals. I was in Iceland with my daughter a few months ago, and I think 5,000 individuals may represent about 25% of the population. Anyway, they were enrolled in a large epidemiological study. They received a hearing examination between the years of 2002 and 2006, and they were followed for mortality through 2009. It turns out that individuals with hearing loss had a higher risk of death resulting from cardiovascular disease than those without. Now, there's a whole literature that studies this association between hearing loss and cardiovascular disease. I'm not covering that today. Just know that that too is a well-established comorbidity and correlation. So here's some data from that Reykjavik study. So looking at our time to event graph, here, death is the event. We can see that males with no or mild hearing loss experienced higher survival rates than those who had hearing impairment, than those with both hearing and visual impairment. So we call this a dual sensory impairment. So again, we see that top line, people still die, even though they don't have much of a hearing loss, but they tend to die quicker if you have a hearing loss, and even quicker if you have a hearing and visual loss. Now, there's a growing literature studying the combined effects of vision and hearing loss. And it turns out that many of those comorbidities that I've described to you tend to have greater risks of occurring if an individual has both hearing and visual loss than either alone. Now I'm going to review the research regarding the effects of amplification on the conditions that we've discussed. It turns out that amplification may have some positive mitigating effects on some of these comorbidities. But Barbara Weinstein and colleagues investigated the effects of hearing aid use on loneliness. What they were able to document was that the use of hearing aids significantly decreased loneliness following 4 to 6 weeks of hearing aid use, both on the total loneliness score and the emotional loneliness subscale score using what's called the De Jonge-Gierveld loneliness scale. This recently published paper supports the benefits of hearing aids and cochlear implants in stabilizing the effects of hearing loss on loneliness. Here we see the UCLA loneliness scale scores on the vertical axis and time on the horizontal axis. And among CI recipients, we can see that the UCLA loneliness score decreases somewhat at 6 months. It returns to about baseline level at the end of the 5 years, but never increases beyond what the score was at baseline. And we see the same situation with people who have hearing aids, and that is loneliness never increases among those who've used hearing aids over a 5-year period. So while it didn't decrease loneliness, it helped to maintain whatever loneliness people described at baseline. And that's important too. You may recall this study that I reviewed, which supported the relationship between hearing loss and depression. When the investigators looked at individuals with hearing loss who wore hearing aids, the odds ratio of being diagnosed with a major depressive disorder or reporting any depressive symptoms were significantly lower than among those who did not wear hearing aids, right? You could see those numbers in the hearing aid column being much lower than in the non-hearing aid use column. Here's an interesting study in terms of falls by Rumala and colleagues that indicated that using hearing aids for 30 days may reduce the risk of falls. Now, the experimental condition here involved measuring the amount of time participants maintain stability on 2 different kinds of postural tests. One, they stand on foam, the other, they put one foot in front of the other. So each of the lines represent the unaided and the aided performance level, performance being the amount of time in seconds that they could stand without kind of losing their balance. And it turns out that when the person was aided, their stability increased. Each of these lines represent one subject. So in almost every subject, stability increased. They were able to stand on that foam or put one foot in front of the other for a longer period of time. This is not a study that we can have much confidence in simply because there's so few people involved in it. So a possible explanation for hearing aids essentially improving balance might be that the brain utilizes sound cues to improve spatial orientation, essentially creating a three-dimensional sound map, which in turn results in improved postural stability. Now, in a contrast, however, is a more recently published study by McDaniel and colleagues, and they use computerized posturography, which is a very sophisticated battery of tests that measure an individual's postural stability. The SOT is called sensory organization test. And the results of this study indicated that the presence or absence of hearing aids really didn't have any effect on postural stability for the participants in the study. So here's an illustration of those results, that regardless of the SOT condition, of which there are six different conditions that test the individual's stability. And here are the scores, the SOT scores on the vertical axis. It really didn't differ. Those scores didn't differ on the basis of whether the participants wore hearing aids or they didn't. In terms of the effect of hearing aids on cognition, Piers Dawes and his colleagues found that hearing aid use had a positive effect on cognition, which was independent of social isolation and depression. That's certainly encouraging news. Here's a study that got a lot of attention in audiology circles. This is Amieva and colleagues who followed some 3,700 participants as part of a population-based aging study in France. And what they found that self-reported hearing loss was associated with lower cognitive test scores at baseline, and that over the 25-year period that these people were followed, there was less cognitive decline among those who wore hearing aids than those who did not. Now, it's important to note that both the hearing loss and hearing aid use were self-reported, so the results must be viewed with some caution here. Here's another recent article on the subject. The researchers here examined longitudinal claims data from a major health insurer, and the data suggests that the use of hearing aids delays the diagnosis of depression, falls, and Alzheimer's disease. So you should be familiar with this time to event illustration. The red solid curves represent those who wore hearing aids, and the blue dashed curves represent those who didn't. So for anxiety and depression, for injurious falls, and for Alzheimer's disease and depression, there's a separation between the curves, some greater separation and some for some disorders than others, but these are significant differences, which indicates a delay in each event among those with hearing aids compared to those without. The Lancet Commission report, very influential report, which was published in 2021, concluded that encouraging the use of hearing aids and reducing hearing loss through the use of hearing protection have the potential to significantly reduce or delay the onset of dementia. As a matter of fact, it's the single most significant mitigating event or feature or strategy that people can take to mitigate the onset and the severity of dementia. So what might explain the beneficial effects of amplification on cognitive function? And this is, we might say it has to do with auditory neuroplasticity. So what's auditory neuroplasticity? Well, it's the brain's ability to reorganize itself in the absence of, or in the of certain information, in this case, auditory information, among people who have hearing loss, or restore those connections and form new connections in the presence of new auditory stimulation, which is brought about by the use of hearing aids. The evidence is fairly compelling that the auditory system is, in fact, neurophysiologically plastic, and that auditory plasticity can be achieved through the use of hearing aids. In this study, the researchers make a strong case for auditory plasticity by examining changes in auditory processing tasks following hearing aid use. So neuroplasticity of the central auditory system may lead to increased neural connections in the brain in the presence of new auditory stimulation that results from hearing aid use. Then these new connections are thought to increase cognitive resources. Remember, we talked about the use of cognitive resources, and it reduces the risk for further decline of cognitive function as these new neural connections get built and grow. So the research evidence strongly points to associations between hearing loss and potential positive impact of audiologic rehabilitation on those associations. What's critically needed, however, are carefully designed, what are called randomized controlled studies, so that we can better understand the nature of those associations and understand perhaps causation rather than just correlation, and implement effective evidence-based interventions. And there are a couple of studies underway. This is a large-scale study, which is pretty much winding down, may be completed, and which is headed by Frank Lin. This is called the ACHIEVE study, and its aim is to determine the effects of best practices hearing rehabilitation on rates of cognitive decline in 70 to 84-year-olds. Study is nearing completion. I think it may be done, and we're eagerly awaiting some of the publications that have resulted from this study. Another ambitious study is close to completion in the EU, and this involves some 7 nations across Europe. I was actually involved in the design of this study when I was with Starkey, as a matter of fact. And among its many aims is to gain a better understanding of the links between hearing, vision, cognition, and emotional systems. And this project is, I think, in the data analysis stage. And again, we should be seeing some publications that report on its results soon. So I'm going to move through this implications for audiologists. And the point here, what I'm trying to make is that there are tools available, particularly cognition and depression screening tools that really should be part of the audiologist toolbox. So in terms of kind of a take-home message here, the results of these studies really clearly send a message to the medical community that age-related hearing loss is not simply a benign consequence of aging, but that it's truly associated with a number of chronic disorders. The other important message is that hearing aids can help to modify many of the consequences of these comorbid conditions, but we do have to be cautious, right? That these are correlation studies, and that the benefits of hearing aids still have not been identified through randomized controlled trials. So for the clinicians in the room, we really have a grand opportunity to educate our patients and the medical community about health-related consequences of untreated hearing loss and the importance of good hearing for effective provider-patient relationships. If nothing else, certainly to improve the ability of the patient to understand what their provider is telling them in terms of their disorder, and to comply with medication and treatment recommendations, and minimizing the opportunities for medical errors. So the first thing clinicians should be doing is updating our history forms to make sure we're asking questions that relate to the conditions associated with hearing loss. Educate ourselves concerning chronic conditions. And by the way, this research is always changing. I mean, not a month goes by that there aren't several papers that are focusing on the relationship between hearing loss and disorders. And these are getting better and better in terms of their design. And furthermore, if we haven't done so already, we need to create or strengthen our relationship with other healthcare professionals in the community. Now, I mentioned about screening tools like cognition and depression screening tools. Now, these are not meant to diagnose, and audiologists shouldn't feel that this is not within their scope of practice. We're merely administering a screening tool. If in fact the results are troublesome, then we need to make sure we have a network of providers to whom we can refer these patients to. Here are the references if you're interested in looking at this. And I know if you want more information, get into a little deeper. I know, Lisa, you've sent out a couple of papers, one of which was a review paper that I recently published. So at this time, any questions?
Thank you there for Harvey. I do know that correlative studies are probably going to be the only thing we can ever do with hearing loss and comorbidities, because there's something about ethics and causing problems that get in the way with some of these causative studies.
Well, yes and no. You can randomize people. Because we don't know for sure, Lisa, you can randomize people, at least into hearing aid or no hearing aid, right? Of course, what you want to be able to do is say, at the end of a certain period of time, we're going to provide you with hearing aids. So it could be delayed treatment, right? And see if in fact you can identify some of these. But there are certain studies, of course, you can't do. So you do have to depend on sort of these population studies to identify those who are wearing hearing aids and those who aren't, and then sort of examine what these consequences are in terms of increased risks if you don't wear hearing aids. But as I said, they're getting more sophisticated. Remember, some of these earlier studies showed a relationship between hearing loss and falls, but more sophisticated statistical treatment failed to support those initial findings because they looked at other comorbidities such as vestibular disorders and just dizziness symptoms as reported by the patient. Once you take that into account, it's not hearing loss that's responsible, it's having a vestibular disorder, right? That you wouldn't identify in a population study, right? You'd just identify the hearing loss and you'd identify people who fall, right?
If anybody does have any questions, feel free to raise your hand or write them in the chat. Karen Puller said the presentation was excellent and was hoping she could get a copy of the slides or recording afterwards to look at. The recording and the captioned recording will be available on the Hearing New Zealand website after this one. And will Harvey will you make your slides available? Would that be okay?
Yeah, absolutely. I'll send you the slide deck, Lisa. All right. So I have a question. I'm always a little concerned because I'm presenting statistics, right? And some research design. Was everybody able to pretty well follow this information and the material?
They're typing. When my father-in-law had his dementia assessment, I knew he had a hearing loss, and the doctor should have known he had a hearing loss because when she asked that one, he did one of those and looked at me. No, I don't have a hearing loss, which should have been the first clue. And since he failed the dementia test and was going to lose his driver's license, I mentioned to him, Jim, if you don't have a hearing loss, you're a gaga and you're going to have to lose your license now. At which point he did admit that he had a hearing loss if it meant his license. We put a headset on him and redid his dementia test. And he went from moderate dementia to borderline in the case of 5 minutes.
I'm so glad you mentioned that. And it was a paper that I just saw today, Lisa. It is a international consensus for clinicians on best practices for vision, hearing, and cognitive disorders. And that's one of their recommendations, is that what you have to make sure that if people are taking a cognitive test, you compensate for whatever hearing loss or visual impairment they have, right? And yes, and this is a great example, and may also reveal some of the shortcomings of earlier studies that demonstrated this link between hearing loss and dementia. So if you have a hearing loss and you don't understand the directions for how to take the cognitive screening test, well, you're not going to do well, are you? Right. Now, or if you have to do something on paper, some of these cognitive tests require you to draw things. And if you're visually impaired, that also is going to affect the outcome of the cognition test. Right.
And self-report's pretty sketchy on whether they actually have hearing loss or not, isn't it? So isn't
well,
how good is self-report?
Yes and no. If you're asking whether or not self-reports correlate with audiometric test data, not very well. They do okay at the two ends. You know, people with near normal hearing, people with severe hearing loss. Self-report and audiometric results will correlate quite well. It's in that middle, kind of that mild, that moderate range of hearing. But don't forget, for instance, your father was asked, do you have a hearing problem? They said, no, I don't. Well, maybe he feels he doesn't. I mean, it's not necessarily denial. Maybe he truly feels he doesn't. And that's part of the problem. What is the context in which an individual is self-reporting? You know, if essentially you live pretty much by yourself and you can turn up the TV, you don't have a hearing problem. I can hear everything that's on the TV. It might drive other people out of the room, right? Now, if you're actively and socially active and you have a hearing loss, you're probably going to notice it, and you will be able to self-report it. Now, I often recommend to physicians, the primary care physicians, don't ask somebody if they think they have a hearing loss. The question is, has anyone told you you have a hearing loss? And that kind of gets away from that self-denial response, right? And may reveal more about the true nature of an individual's hearing than just asking the individual if they think they have a hearing, or do you have a hearing loss, right?
Jackie Taylor wants to know what a good, simple screening tool for the use of cognition and depression.
Oh, so if we have a little time, let me go back to sharing my slides. And so here is cognition. Now here's several tests here, screening tests. These are the MoCA. There's what's called clock drawing. There's letter numbering, sequencing, and reading span test. But this one, the 6CIT thing, I think is brilliant, right? So the 6CIT, 6-item cognitive impairment test, has been around for 40 years and had been used, I don't know if it still is, in primary care. And it uses this inverse scoring method. So 0 to 7 is normal, 8 to 9 mild, 10 to 28 is significant cognitive impairment. So here are the items. They're really fast, right? What is the year? What is the month? I'm going to read this address to you, repeat it back to me. It gets to working memory. Well, what time is it? Number 5, count backwards from 20 out loud. 6, recite the months of the year backwards. And number 7 is, hey, remember that address? Can you repeat it? This gets to short-term memory. That's a 6CIT test. It's wonderful, right? Now, in terms of depression, there are, again, a number of tests, but this last one, Patient Health Questionnaire, the PHQ-9, here are the questions, 9 questions. Individual reports whether this happens to them from never to nearly every day. You count up the points. And 5 to 9 is minimal symptoms, 10 to 14 minor depression, 15 to 19 major depression to moderately severe, and above 20, major depression, severe. And you can see what treatment recommendations are here. So again, I'm not advocating that you use this as a diagnostic tool, but as a screening tool, certainly to help you perhaps refer this individual to the appropriate specialist, right? Now, I think another question is, who do you administer this to? Everybody? Or perhaps you may, in reviewing an individual's medical record, you might have suspicion that depression may be a problem. I think for many of us in the clinic, we suspect sometimes individual with cognitive problems, because they often will ask the same question repeatedly. Sometimes if they're there with a family member will voice concern. And certainly in that case, it'd be appropriate to administer a screening test. Other people just do it as a matter of routine to individuals above a certain age. Right.
Charmaine Fowler said that her husband's cognitive test was done by a person that English was not the first language, spoke very softly, and did not take into account the consideration he had a hearing impairment. He was diagnosed with cognitive impairment and was very challenging to get this changed on his medical forms. She also lets us know that the MOCA in New Zealand can only be used if you have a license, and in New Zealand we use the mini ACE.
Okay, that's similar in the States as well. So that's why the 6CIT kind of gets around that particular prohibition, right? Again, because you're not, the MMSE or the MOCA tends to be more diagnostic, whereas a 6CIT is just a quick screening test. Right. But the point, was it Charmaine?
Charmaine, yep.
Charmaine, yeah, it's the same comment you made, Lisa, and I think many clinicians are unaware of the effect of hearing loss on test results, cognitive test results. And how do you? I think it just requires education among clinicians and even among family members to make sure if their loved one is being administered a test that, and they know this person has a hearing loss, that the person administering the test somehow compensates for that.
And in answer to your question, Harvey, most of the feedback was all of the feedback was very positive, that it was clear, easy to read. A few people thought you might have been a little bit fast in your speech, but that may be our New Zealand ears rather than your, with your American accent.
Oh yeah, I think I'm afraid that's my nature. I tend to speak quickly. And a part of it too, I want, of course, you want to get through a certain amount of information in the time allotted. So I apologize for that. Anybody who wants further, has a specific question, again, feel free to email me at any of these addresses. I'd be happy to provide you with additional information. And again, oh, by the way, there's also, in addition to that white paper in 2022, Lisa, that's a second paper. I did one, I think in 2017, that's referred to in the 2022 paper. In that first one, I talk about some of these epidemiological terms. So if you can get your hands on that, and if you can, I'll send that to you. You can share it with members of the organization.
Great. And I do appreciate your time, Harvey. I really enjoyed the presentation, and it's always good to remember what those comorbidities are and how much the whole person is affected.
Indeed, of course, great. And again, thank you for this invitation. This was a lot of fun. I enjoyed it.
Next month will be on pharmacological and gene therapies for repairing hearing loss. So we will be sending that link out, or it is on our website. Thank you all for attending, and we will see you hopefully next month. Thanks again, Harvey. Have a good one.
You're welcome. Bye-bye, everybody.
Bye. Oh, Tom.